Welcome to our medical panel, facilitated by Dr. Chad Ruoff. We have Dr. Emmanuel Mignot, Dr. Kiran Maski, Dr. Michael Thorpy, and Dr. Lois Krahn on our panel today. Thank you for joining us. Quick note about questions. For this panel, we're asking you write your questions on the index cards on your table so that we can ensure as many of your questions are addressed by our panel as possible. Please write your questions neatly on the cards. When you're finished, hold them up, and monitors will be collected for you. All right, that's it. I'll turn it over to Dr. Ruoff.
I would just add, please make them succinct questions, because I'm going to be the one reading them up here, and legible as much as possible. No one in here is probably used to writing. I wish they had to write. For this, I wrote notes. I was like, my gosh, my handwriting. All right, so let's get started here. So typically this is a Dr. Thorpy thing, facilitating, I feel like. He's the expert at facilitating, so I'm going to try my hat at it today. All right. So our agenda. So we're going to go through Narcolepsy 101. Anything and everything. You've been delivered the diagnosis of narcolepsy. What kind of questions come to mind that you would want to ask your physician, your care providers? You have an opportunity to get 4 consults, 4 opinions up here. So fire those questions away, and we'll first tackle that topic. I'd like to go through each section, and so focus your questions according to this agenda. Oh, crud. You guys are, I'm looking at it. I can see it here. You guys can't see it? Come on now. Yeah, so this is kind of our agenda. So Narcolepsy 101, and then we'll delve into some talking about medications, FDA-approved medications, and then evaluating effectiveness, so outcome measures. How frequently should you be seen, or are you being seen? What are docs asking patients at follow-up, that sort of a thing. And then just talk about clinical trials. What are the pros, cons? What kind of tests are done? Should you do it? Are you the right patient? And then we'll turn it over to audience questions at the end, but try to trickle those index cards in as we go through here. So I'll kick it off, but I'm going to rely heavily upon your questions. So fire those off as well. So, and I might at times act like a patient asking the panel questions, because ultimately that's the beauty here, right? So you get 4 opinions. So I guess I'm showing up as a follow-up, and I just had my PSG MSLT, and it says I have narcolepsy. I mean, how do you deliver this diagnosis? What do you tell the patient it means? How do you broach this topic? How do you summarize? Don't talk about the details of the test, but the test is positive, and what do you tell the patient? And it's type 2 narcolepsy. It's not narcolepsy type 1. And Dr. Mignot raised his hand, so we'll start there. This is actually putting him into a little bit of a precarious situation, because
I know I'm going to say some things that Lois Krahn was going to say. We can't consider this as real medical advice, because
yes,
we don't see patients, and it's always a bit dangerous. You can make a mistake, by not really going through all the medical, things and knowing the history of the patient. So just keep that in mind. Isn't that what you wanted to say? I know her, Yeah. But of course, she had a very important administrative job, not like me, So anyway, so how do you deliver this? I mean, as you probably have seen, I'm an optimist more than a pessimist. So I always deliver, I would generally explain what are the different types of narcolepsy, the narcolepsy type 1, the narcolepsy type 2. Then I explain that it's most likely narcolepsy type 2 if the patient doesn't have cataplexy. And I say there is good news and bad news. The good news is that we don't really know, the bad news is we really don't know what is causing the problem. But the good news is, as a consequence, we don't really know how it's going to evolve. And sometimes people get out of the narcolepsy type 2 with time, with age, etc. And the test is really not that meaningful. What's very important is more to treat the patients with different medication, with minimizing the possibility of harm. But I think, I don't know how much you want me to go, because it could go on and on and on. But in general, I think I try to explain that there's 2 types of narcolepsy. One, we know the cause. And then when we know the cause, I say, it's good news and bad news. It's good news because we know the cause, we know what you have. This is ending your quest for finding a reason, and the bad news is you will have it for life. Whereas the other, I say it's good news because it's bad news because we don't know what you have really, but it's good news in the sense that it may not be irreversible, and there are treatments that are working, and that we can certainly treat you very effectively as well. So I think that's a little bit how I approach the question.
Yeah, and then I guess Dr. Maski, I guess, so patient presents with a negative test, and they're excessively sleepy, and
you're changing the game in the middle.
I know. Well, does the panel have any other thoughts on that? Well, anything else that you just high level when a patient comes in and asks, you know?
With the first scenario, I guess can you hear me okay?
Lean very close, yeah.
Okay. The only thing I'll add is that we also typically check the HLA typing of all patients.
Interesting.
And if they have HLA positive and they met the diagnosis of narcolepsy type 2, meaning they haven't developed cataplexy yet, that's additional information I might provide from this guy's data that basically says that it's possible that they might develop cataplexy years to even sometimes decades later, and that might be even more true in the African American population.
And keep in mind, and this actually I had you targeted for this kind of topic, is so as a pediatric neurologist, prognosis I think is very important when a parent comes in with their child and they have a positive MSLT, and especially maybe they don't have cataplexy, right? So we don't know the pathophysiology of this condition. And so it's nice to hear that you pretty much are reflexively ordering HLA on all patients.
And I also do
for prognosis. HLA, And recall Dr. Mignot's talk and Dr. Thorpy's, right? So for narcolepsy type 1, pretty much 100%. Just think of it 98%. Just think about 100%. If you're positive for the HLA, then you might have narcolepsy type 1. It's not diagnostic. But if it's negative, it really makes it much, much, much less likely. And that might be actually a good question for the panel as well. Holy moly. Yeah.
So I'll give this one a try. I also am an optimist, and I'll often say to the patient, this really helps explain why you're here and what you've been struggling with, because many people who have never been diagnosed and are newly diagnosed have had a pretty long path before they see a physician who helps understand why they've been having such a hard time. And the other thing I will add in is, although there's no great time to be diagnosed with a medical problem, that in 2022, we have more knowledge and more tools to help than we used to. And that going forward, I am very convinced that pattern will continue, and that we likely will have more options in the future than we have now. And so my hope is that just helps someone come to terms with the fact that they have a long-term serious medical condition that we now can pinpoint and put a name on.
Yeah, I'd just like...
Okay, good.
It's working. I'd just like to add to that. Narcolepsy is very different from most other medical conditions. I mean, if you've got somebody who's got a cough and you do a chest x-ray and you find that they've got a lung tumor and you're seeing them back and you're telling them about that diagnosis, it's very different than with narcolepsy. I mean, usually, and as Laura mentioned, the course has been quite prolonged by the time they come to you. And if you're telling somebody once you get the results of the MSLT, I mean, you've seen them before you do the test. So you start the process. I mean, they have probably already largely read up and probably have an inkling that they might have narcolepsy by the time they come to present. It may be a bit different for children where they may not have so much information before they come. But for adults, they generally have some inkling about what the potential causes of the problem are. But certainly you're going to talk to them initially, and then you're going to talk about the MSLT and why we're doing it, and then you get the results, and then you talk to them. So it's not like looking at an x-ray and saying, right, you've got this condition. That would be very different. You're really sort of leading the patient towards a diagnosis of narcolepsy if you suspect that at the first interview. And then so it's a more of a prolonged course.
It's earlier when we had the patient panel up here, I did highlight just in the general population sleepiness and how it can remit, right? It was 20, depending upon the study you read, 20, 30% of general sleepiness and sleepiness in the general population remits. And so that's the optimist kind of attitude with a narcolepsy type 2, HLA negative kind of diagnosis. We don't understand the pathophysiology. And so one thing to be mindful of too, I think is do you medicate, I guess, Dr. Maski, I'm picking on you because of pediatrics. I mean, how do you approach this subject if it is a type 2 HLA negative? Are you aggressive with the medications, or how do you decide? Behavioral treatments or?
Yeah, no, I mean, I think that for the most part, we're treating symptoms based on how functionally disabled patients are. So usually that's daytime sleepiness is the biggest concern. I personally don't hear a lot of disrupted nighttime sleep concerns, or if there's sleep paralysis or hypnagogic hallucinations, it's much lesser frequency or intensity than the type 1. So daytime sleepiness is typically where we focus our attention. So we're in pediatrics, we're a little bit more limited, as I mentioned before, but stimulants are usually the first line treatment. If a patient has anxiety or depression, perhaps we'll jump to modafinil or armodafinil, and consider pitolisant. I mean, I think if their insurance is reasonable, solriamfetol, in the older population as well. So yeah, I think it is still focused very similarly like how we approach type 1.
Just to extend that question, I guess, do you ever, so like with certain conditions, you might pull the medication back and see if the symptoms still exist. Do you ever do that? Does anyone ever practice that, to wean down the medications to see how they're doing off the meds?
Just want to say there is one group of medication that I try to avoid in patients that are narcolepsy type 2, or when I'm not sure, it's a short-term acting stimulant.
Yeah, good point.
Because I think, the short-term Ritalin or amphetamines, they have the tendency of being addictive in anybody, because they give you a high and then a low, and then you kind of crash, so you take it again, and then you just go up and down. And that, I think, fuel a tendency of taking higher doses. And for reason we don't know, people with narcolepsy type 1 are a little bit maybe less susceptible to developing this kind of addiction potential, but in narcolepsy type 2, I think it can be a bit dangerous. Where people end up with very high doses of this medication, and it's difficult to stop, and then you can have cardiovascular problem, etc., and you can make the picture worse. So that comes back to also your other questions, is how you potentially have to change this kind of things is sometimes a bit difficult when you have someone that has gone the wrong path.
Yeah, I would agree entirely with that. I think I personally also try to avoid the stimulants right from the beginning. And very often, unfortunately, it's not uncommon to get patients referred who have a presumptive diagnosis of narcolepsy, and unfortunately the primary care physician has already put them on the stimulant. And that's one of the worst situations I find, because it's difficult to get them off, and it's difficult to substantiate the diagnosis if they're already taking high doses of amphetamines or so. And so I think they're best avoided, and it's very difficult to get a patient off. In fact, I think it's difficult to get a patient who doesn't have narcolepsy off amphetamines if they're taking them, let alone a patient with narcolepsy. So best to sort of try to hold that. I mean, I do have patients who are on stimulants, amphetamines and methylphenidate. Very often they're patients who have been taking them for a long, long time, and it's not easy to change them over to newer medications. Or they're patients who for one reason or another, all the other alternatives are not effective, or there are problems, so I put them on those medications. So it's not that I totally avoid them, but I would prefer patients not to be on them if at all possible, because of the reasons Emmanuel just mentioned.
But I think I still use them, I just want to make sure, but I think I really avoid the non-extended release formulation. I think there's an increasing evidence that it's a short-acting release that are much more addictive, because they give you this high and low, and the long-acting are not, as addictive. So I think there's a lot less problem if you use like Concerta or, a slow-acting, or Adderall XR. That's a very different game than like Ritalin immediate release or Adderall immediate release. And in fact, often people who are on the short-acting don't want to switch to the extended release, which is very typical. It's always difficult. They say it's not as effective. They try a lot of. They have a lot of reason to say no. It's not as good as as it is, which is a little bit like a sign that actually it is addictive.
Yeah. And to answer the question about do we ever stop the medicine to figure out the diagnosis, I can't think that we do that very much, but occasionally life means that somebody stops the medicine. They have an insurance problem, they're traveling, there's a hitch somewhere. I find it hard to draw conclusions from that if a person abruptly stops a medicine, because then they kind of get into a rebound situation. It's a bit of a response to an immediate stop. When a person needs to stop for one reason or another, I personally greatly prefer that they're on a longer acting medicine, because then there's sort of a natural tapering that's sort of built in because of the way that medicine works, and also that we gradually reduce the dose, so it's a much softer transition, and hopefully the potential for a person having what we call rebound sleepiness is decreased.
And then,
before you do, I'd just like to address the issue that you made about what medication are you going to start with, and whether you use something sort of milder or stronger. Personally, if I feel that if a patient has reached the criteria for type 2 narcolepsy, that means they have a mean sleep latency of less than 8 minutes, they have 2 or more sleep onset REM periods, then they're significantly impaired. And I want them to get the best treatment. I don't think I'm going to try to give them something that's going to sort of partially improve them because, you've got a patient who might have 8 minutes and 2 sleep onset REM periods compared with somebody who falls asleep in 1 minute and has 5 sleep onset REM periods. I want them both to get the optimum treatment, because we know that even with the best treatment in narcolepsy, it's impossible to make a patient with narcolepsy entirely normal again. I mean, they're not 100% back. It's a very difficult condition to treat, and I want them to get the best treatment. So whatever I decide is the most effective drug for treating narcolepsy, that's what I'm going to propose first. They may or may not be able to take it for various reasons, but it's a little bit like sleep apnea. When you treat sleep apnea in patients, they're very sleepy to start with. You put them on CPAP, and they get better, and they go from a level of sleepiness down here to one up here, and they think, that's fantastic, I'm great, but really normal is up here. And I think it's the same with the narcoleptic. I think, if you try a lesser treatment or an inadequate dose of treatment, you just treat them partially, they'll notice improvement. They'll go from there to there, but really I want them to be up here, back to as close to normal as possible.
So I was guilty of that off topic. We're trying to do Narcolepsy 101, so patients first presenting and asking questions. So thank you, audience, for someone in the audience for asking this question. Multiple HLA markers, how common, question mark, impact, question mark. That's what the card reads. So as you heard in Dr. Mignot's talk, and probably everyone else's, HLA DQB 10602.
That's
the most
French
specific
accent,
marker. So I guess I'll let someone from the panel take this. There are. There's HLAs for celiac, and actually Dr. Krahn can also talk what she did at Mayo Clinic to help with this issue as well, so there wasn't any confusion about how to order the test. Go ahead.
I'll just answer. So what at Mayo Clinic we did is we have a very large HLA lab that primarily works with our transplant team, because if you get an organ transplant, you really need the new organ to match the recipient's HLA, amongst other things. So I asked them, could they create a new test that is for DQB 10602, period, yes, no. And so then we call it a narcolepsy-associated antigen, and it really makes it easier for someone to order and get that. Now, my question to Dr. Mignot is, are we missing something if we're that precise looking yes, no for that one allele?
my question to Dr. Krahn is the test that tests only for DQB10602 cheaper?
Yes.
Oh, good. Because the problem, is that these transplantation tests are very expensive. And what I'm always outraged because they charge like $600 or $800 for doing this test, was when I do it in my lab, I think they use my same test.
Probably.
That I designed one in the lab that only looks for DQB10602, and it's very effective. It works super well. There's almost no false positive, and it costs literally nothing. So, I wish that more people would develop it commercially. I don't know to sell this stuff, but it will be very easy to do, and I'm happy that I think that's what they did because I was in contact with them. And yes, we're missing a little bit, but that's really for the ultra nerd, because, if you have DQB10602, then you are much at risk. Again, it's almost you have to do it to develop type 1 narcolepsy with low hypocretin. And then if you don't have it, that's quite rare. But then if you have it, there's also a little bit more risk to developing narcolepsy type 1 with low hypocretin if you have 2 copies of it, or you have an earlier age of onset when you have DQB10602 or 301. So there is like some little bit of things that make a tiny bit of a difference, but honestly, clinically, I think it's negligible. It just increases a little bit the risk, but overall, almost 90% of the risk is carried of whether or not you have this. So I don't think it's useful clinically. What's useful clinically is to know if you have it or not. After that, it's really for the ultra nerd like me, or maybe some of us. I think if you really want to know, you could. Of course, I'm always curious. I always look and say, it's 2 copies, so it's even slightly more probable. But truly, it's not giving a lot of additional information.
Just had an audience question, if you don't mind. You don't have to raise your hand if you don't want to vote.
Actually, I would like to say one thing. I think there's not only HLA DQB10602, and yeah, that's absolutely typical for narcolepsy, yeah. So,
and I'll get your phone back.
Yes, so it's HLA DQB10602 and HLA DQA1 or 102, and they're usually always together. That's why if you have the 0602, it's almost not worth it to look at 0102 because they're always together. So that's why we only test for 0602.
And who in the audience has had HLA testing? We've talked a lot about it.
Wow.
Not so many.
Yeah, not so many. But I wanted to point out that now there is some new genetic. I'm sure you have heard, you have seen on this slide that I show that you can screen the entire genome, and now you can do a little bit better with almost the same cost. Actually, for about $50, I can do an entire genome, and with the genome, I can actually derive the HLA and also all the other genes that increase narcolepsy probability. So it's a little bit better, but it's a little bit more complicated to explain to a clinician, but we can do what's called a polygenic risk score, and we can actually, exclude a little bit more people who have narcolepsy, even so they are 0602 positive. But it just maybe improves a little bit the specificity, maybe instead of 25% of people positive, maybe like 10%, but it's still a little bit more predictive, but it's not absolute. That's the problem.
Who other than you can do this?
Sorry?
Who other than you can do this?
I think
anyone else that's doing?
No, I think anybody could do it. It's just
you can send off for this and.
No. It will take. There's a mathematical formula, but I think we'll publish this soon, and I think other people will. More and more research is going in that direction,
right. Okay.
So I think it will happen.
Good.
So I just want to make one last point.
But again, it only was slightly better. It's like 0602 is really the best and most important.
Now, I'm going to sound a bit like a nerd, but occasionally we will have a patient, I'll say rarely, we will have a patient who has very convincing cataplexy and is HLA negative.
Yep.
And in that case,
Yep.
We will arrange to have a spinal tap done and measure an orexin level. And very often, we will also think a little more about something like an MRI of the brain, because there are patients who can be HLA negative, who have hypocretin deficiency. It's rare, but they're more likely to have something like optic neuritis or multiple sclerosis or some kind of brain disease. So this is not your garden variety form of narcolepsy. It's a little more secondary to something else. But, as Dr. Ruoff knows, when we encounter one of these, we tend to sort of bring in everybody to take a close look and confirm that we've done everything correctly. But there are some people who are in that situation.
Yes, I want to say this.
Yes.
We're all doctors. It's very important to understand this very simple thing. If you're a doctor, there's always an exception. There is nothing like a perfect rule. It just doesn't exist in medicine. You always have someone that has a little bit of a different picture. So I have never seen a perfect rule. We find even patients who have low hypocretin of the HLA negative. It's extremely rare, but I've seen some myself. And we find people who have not the HLA and as normal hypocretin, and we see people without the HLA with normal hypocretin and have a convincing picture. But of course those are more rare. And then of course you don't understand as well what's happening, so you put them in that category, I don't really know, and often you will treat them a little bit more like narcolepsy type 2 in general, but that doesn't mean you won't treat them as any patients.
Just to make sure we're talking, I just committed the observation. Just lean forward and talk directly into the microphone, please. All right. So, given the low frequency of HLA testing in the room, I don't want everyone to go off and scurry and ask their primary care, their sleep doctor to get an HLA. So succinctly, because I want to move on, given how few HLA testings out there, who should get the HLA? Or just very general couple sentences, and why, prognosis, or why. If someone's doing well on treatment, there's no question about diagnosis. They've been on, stable. Should they go out and get an HLA?
I'll say, in that case, I don't see that it would add enough value to merit the test. So if things are going well and you don't know your HLA, I don't know that is your highest priority.
And you don't have any atypical findings, or only cataplexy caused by negative emotion, that's it, something like that, then yeah. How often, so kind of similar thought, how often should you have a sleep study redone once you have been diagnosed? We could spend a lot of time on this, but I'll just, for the panelists, the MSLT was done perfectly. You trust it. They weren't on any medications. You have no doubts about the diagnosis. Should you repeat? And if so, when, how, why?
No, so if the patient
really
is very
good questions,
If the patient's very symptomatic and has all the typical symptoms, and you got a positive test, there's absolutely no reason to repeat it at all. It's only if something very unusual happens, like the patient now comes and says, well, all my symptoms are gone away, then maybe you'd repeat it. But I mean, if somebody is symptomatic, they've had a very positive test, there's no need to repeat it again.
Everyone in the room, make sure next to your Social Security card you have your PSG and MSLT. Repeat.
Yes.
Next to your birth certificate, your Social Security card, if you have a diagnosis of narcolepsy, make sure you keep track of those papers.
I would say that, sorry.
Oh, I'll just, one thing. Sometimes if you want to be in a clinical trial, they will have some rules, and they'll say your test results must be no more than 10 years old. Now, sometimes we can sort of appeal that and ask for an exception, but that is one scenario where often the sponsor of the clinical trial will cover the cost, and they just are wanting to do good quality research. It's quite a hassle when that's part of it, but I've encountered in that situation where a person wants to do something a little bit different and there's a new requirement.
And then I'm just going to extend this question. Go ahead, Dr. Mignot.
But I would say that the MSLT has one main purpose: insurance. I mean, to be absolutely honest, very often, and in the past, unfortunately, you know that I'm one of the oldest in the panel, and when that was first described, narcolepsy, we didn't even need an MSLT. If cataplexy was sufficiently clear, you didn't even need a cataplexy. And sometimes I see a patient, especially young patients, they enter in my room, I don't even need an MSLT, I know immediately, and I can say it's DQB 10602, there is no doubt, and unfortunately I'm never wrong. But
He's talking primarily about narcolepsy type 1.
yeah, with narcolepsy type 1. But what I want to, and the MSLT will be positive and everything will be, like textbook. So, I mean, I think the MSLT in some ways is not always indispensable, of course. But unfortunately, the insurance, the brain of insurance is very limited. They have many people working, but their IQ as a mean is very, very low. And they just don't know that sometimes the doctors is right. They think that, you have to do it this way and not other way. And so you have to follow things. And the positive MSLT gives you more opportunity because they still believe in it. And then they will give you less trouble to reimburse certain medication, etc., because they differentiate between narcolepsy type 2 and idiopathic hypersomnia, even so now there's more and more evidence that it's not so different. And there's definitely some people, sometimes they have an MSLT with no SORM, and they suffer enormously, and they need to be treated, but it's harder than if they have the SORM and they have a narcolepsy type 2 diagnosis. So it's totally absurd. It has no reason to be there, but that's just because the insurance company have a very limited IQ, and we have sometimes to write these letters, etc. And so I would say that if you have a positive MSLT, just frame it, because because it allows you to maybe get better insurance. And if you don't have a positive MSLT and you are type 2, repeat the MSLT 20 times and eventually it will be positive. No, I'm joking. So I'm not claiming this, but it's a little bit true.
This is actually more of a monitoring, but while we're talking about repeat or not repeat a sleep test, and I would divide that up into the overnight test, a home test, or an MSLT. In what situations would you repeat a test, an overnight test?
Yeah, I think maybe...
when might that come up?
So
I give you a hint, a patient comes in and says all of a sudden they're snoring or something like that.
Yeah, that's what I was just going to say. I mean, I would say if the symptoms are not, or suddenly symptoms of sleepiness resume and you're snoring, choking, have apnea, that would be a good reason to look for secondary comorbidities such as obstructive sleep apnea. I don't know, we're because so many of patients that we see clinically were initially diagnosed with obstructive sleep apnea, we usually find that they had a sleep study once and then we're repeating it for the diagnosis. And we are seeing that there are changes in the pediatric population, that disrupted nighttime sleep might actually get worse with time, but that's not a clinical reason to do it for that purpose.
And it's only a sleep study
yes,
at night.
Just the
At
night.
night.
So
Yeah.
it's quite rare that
Could
we
be a
repeat
medication
the
side
MSLT,
effect or
you know.
something.
The other reason for doing it is if somebody's put on oxybate
There you
and
go.
then they develop some symptoms of sleep apnea, it may be worthwhile repeating the overnight sleep study just to make sure that it's
But
mild or
not the
minimal, but
MSLT.
not more
Right,
severe.
Exactly. Yeah.
It's very rare to have to repeat the MSLT unless you really want to have a positive test for insurance purpose. But otherwise, I think really it's more the night sleep as exactly the two they mentioned, to make sure that there's not something else that explains if the patient is not doing well. So also sometime when the patient is not reacting normally to sodium oxybate, has some weird symptoms, you just feel something is not right, so you want to clarify it, so it's useful to do. And the last one, just to tell you the insurance, because the last one was the most interesting. I had a patient on Xyrem not doing well, and then I tried to write a letter to the insurance to check for sleep apnea, exactly like Dr. Thorpy mentioned. And they explained to me that they were not covered during sleep apnea. So I had to write, I want to do a sleep state-specific changes in oxygen saturation to make sure that they would
That's so
approve
silly.
the study. Yeah.
I just want to make a comment with what Dr. Emmanuel Mignot said about the framing your certificate. Too often I see patients who come to me as sort of a tertiary referral for narcolepsy, and they've gone through other sleep centers, they've had tests done, but they just don't have any of the results whatsoever. And I just want to encourage you, I think every patient with narcolepsy should expect to get the results of their tests done or their reports, and they should keep it in a file, because you don't know what the future holds, and it's going to make a difference with regards to new medications. I mean, as you've seen, a lot of new medications coming up. Insurance companies are going to limit access to them because they're all going to be much more expensive, even though they may be more effective. And so you need that information. So I encourage everyone, keep your own file on your own reports.
And if I can add to that, don't expect to be able to go back to the place where you had the test done and get a copy from them. Some places like Mayo Clinic, we keep things forever. But other places will retain records for 7 years.
7 years.
And then will dispose of them. And we sometimes will try and help a person get records from a previous testing center. And it's quite common to get a note saying that was so long ago that we no longer have those records. So please keep your own file.
Yeah. And the other thing about that I just want to mention is, if you're going to see a physician, don't have that physician request the information from your previous hospital. You request it and have it sent to you, and then you pass it on to your new physician. Too often things get lost transitioning between one institution and another. Yeah. And at least if you ask for it to come to yourself, you know whether it's been received or not. And
it's kind of amazing, you know, the bureaucracy is such that things disappear and you don't know where they disappear. Right. I swear it has been sent 5 times, and you know, and then somehow our nurse said, we never received it. We have no idea. I don't know if someone else find it, the wrong fax number, it was never sent, the person claims they have sent it, and we spend our time, you know, doing this kind of thing. So you're absolutely right. It's so much better when you have it, because you take your stuff. Don't trust doctors, except us, you know. No, I'm exaggerating. But don't, actually, you can trust doctor, but the whole kind of bureaucracy that's with it is really very heavy, complicated, and unfortunately, a lot of things are lost in transfer, you know.
So I'll just read it. This is just trying to take audience questions here. So it is known that medical providers frequently do not recognize narcolepsy. What is being done at your medical school level or your institution or above to educate providers? Anyone want to take a stab at this? This is sorely needed.
Well, I will. I have the opportunity to work with medical students. 4th-year students come and spend a short period of time with us, which is wonderful. And so I've been inquiring, you know, how much do you know about narcolepsy? And I am delighted. Now, this is the school that is at Mayo Clinic, but they know. And they, so it is now in the curriculum of more and more medical students. So I do think that this problem is getting better. And I do think what has made a difference is because it's better understood, it's easier for a medical school professor to say, now we're going to take some time to talk about an important sleep disorder. If something is a little more vague, then it tends to be reserved for a more senior student, let's say a resident. But when, you know, we know, for example, about the association in type 1 narcolepsy with cataplexy with hypocretin orexin, then that's something that's easier to teach and to put on the test. And students are very sure to know what's going to be on the test.
And they love the dogs, you know.
I think it's... But
nobody remembers me, but the dogs, they always remember.
I'd say maybe this is a little optimistic, but I think at the medical school level, I think it's improving. I just gave a lecture on a pulmonary section to med students, and I got an opportunity to talk about narcolepsy and RBD and restless legs and other things. So I think it's improving.
Sorry,
improving.
Chad, sorry, go ahead.
Yeah, you
No,
should
I was
talk
just
about
going to add that I think one area that we need help in is sort of increasing the diversity of diagnosing narcolepsy in different populations, African American, Hispanic populations, where we know narcolepsy lives. So at least in our institution, we're trying to make inroads into the community hospitals. I mentioned that survey we developed. We had it translated into Spanish, for instance, and now we're going out there to educate them on just sleepiness. They might not necessarily be interested in narcolepsy specifically, but they certainly have a lot of sleepy kids. And so we kind of tuck narcolepsy into that package.
Yeah, I absolutely agree. I mean, I think if I just look at my patient community, I see that it's not at all representative of the US population. I mean, certainly I'm in California, so there's not a lot of African Americans. But I know that even my research database, there's a lot less African Americans, there's a lot of less Latino, even so in California there should be a lot of Latinos. And clearly, it's not just the fault of the doctor. I think it's also certain doctors that are not as well educated in this, in these communities, for sure. But it's also because the patients sometimes, they don't realize that sleepiness can be a disease, that they feel that. I will give you a story which is true, is in all my days where I was trying to explain narcolepsy to different people. One day I was interviewed by a TV crew from Australia, and the person had, that was recording the sound. I was explaining all the symptoms, and the person said, "Oh, doc, I think I have your disease." And he had all the symptoms, cataplexy, everything. But he had never really told the doctors because he felt, that's a little bit, I'm like this, I'm more tired than other people. Sleep is kind of a normal thing. Sometimes it's not just the doctor, it's also that the patients don't really come up with the symptoms because they don't realize that it can be a disease to be sleepy. And so I think we need to, and that I think occurs a lot more, in my opinion, in underserved community where probably these patients, work 2 jobs, they're in lower socioeconomic conditions, they are tired, they just struggle already. So for them, it's just one more problem. So I feel very strongly that, and also I've seen, unfortunately, that in this community, sometimes they just, we lose them to the medical care because they have so many other problems. So I think we have to make a much stronger effort to reach out this community.
All right, more questions are coming.
I'm just going to tell one little story.
Sure.
So about 2 weeks ago, an 18-year-old came to see us because she knew we were running a clinical trial, and she wanted to be a participant. And she'd never been diagnosed, but she said, "I've watched a lot of videos, and I think I have that." So we did the testing. She'd never been on any treatment, so it was pretty easy to do the testing. Dr. Ruoff read that sleep study, and you know what? She was right. So sometimes social media can help people recognize for themselves, and then, because of the clinical trial, she didn't need to have insurance. She just could come. And so, now we have the opportunity to assist her. But she was the one that looked around and said, "I think I need to go look for help."
Yeah, unique, but one of our sections is clinical trials, so that's a potential benefit, right? Sometimes these trials are designed so that they can get free testing.
So I want to add something because I feel so strongly about it.
Sure.
So
Just make it succinct, Dr.
And
Mignot.
years I've been trying to convince the pharmaceutical industry that the right way to help patients with narcolepsy may not always be to go through doctors and giving them the 20-year skill about cataplexy that has already been tried 200 times and recommended. But
Talking in the mic here.
Instead of trying to diagnose patients with the doctors, that maybe trying to diagnose directly patients, through outreach, etc. We see, for example, in Italy, they had a very simple cartoon with Alberto Lupi, which was like a little wolf that's like kids that had, I met the cartoonist, and he developed a little series of cartoons about narcolepsy, and they became very popular and so forth. I mean, he has more narcoleptic children than anybody else in the world. So clearly, there's something that we're missing, and I think we need to reach out to the population directly. And I don't know the media, maybe it's TikTok, maybe it's whatever, TikTok, maybe that will work, but we need to find new ways to directly get to the patients.
Is there a relationship between narcolepsy type 1 and autism? Changing abruptly the subject. But
Okay.
that was one of the questions.
I do have some patients with narcolepsy type 1 who are autistic, and I had to look into this. In data registries, something like 3% of narcolepsy type 1 patients have a diagnosis of autism. So it's not a strong, association, but it is interesting. I don't know if you have more experience.
I don't know if we all have some patients with comorbidity, of course. But I don't see that especially more common. But of course, one of the difficulty is if someone has autism, they may come less often to see me because they have another problem in addition. So it's very difficult to know if it's more common or less common because the data is very biased, you know. So I think one more common problem and very terrible problem is the association of narcolepsy with schizophrenia, which I think it is a true association. I don't know if it's, but I think it's probably a bit more frequent than the general population, but I'm not sure. But it's a very difficult association, and I think we need to research that more because maybe there are ways to treat it that could make a big difference.
So getting back to that patient-physician-provider relationship, patient presenting with the diagnosis, and patient says, "What does my past concussion or potentially traumatic brain injury, does that play a role in why I might have developed narcolepsy and hypersomnia? TBI and head injuries."
Well, I mean, it comes up in the differential. I think there has been some reporting that people with narcolepsy have had. There certainly is that in the history. But I would say that it has to be a pretty severe brain injury to cause hypocretin deficiency, something that caused like hypothalamic injury that it's not just like a bump to the head or soccer ball to the head kind of thing. That's my impression of it.
But there is a like a post-traumatic hypersomnia condition that you can see after
Right.
with TBIs
But that recovers.
Right, exactly.
Yes, and
that hopefully
I think,
recovers.
in fact,
that you don't want to over-medicate.
In fact, there have been studies of post-traumatic brain injury, and there's also equally frequently insomnia as a very strong symptom. So I think when you have a hit in the head, things get disrupted in both directions.
Yeah.
And sleep, which is a very good way of looking at your brain health, really gets often very disrupted one way or another. And whether or not it's really narcolepsy is difficult to tell. Now, there are also very rare cases where you have a tumor or you have head trauma and they develop type 1 narcolepsy, and that has been reported, but it's very difficult to tell if it's chance or if it's true. There is a good theory that it could be true because, of course, the cells that kind of attacks the brain, the immune cells have to go into the brain, so maybe sometimes it's one more thing that pushes them to the edge. Yeah. We don't really know, but there's no consistent association, I would say. I know that a story of someone that was stung by a bee and 4 days later, had a big reaction, developed narcolepsy. I mean, so is that relevant? There's always some stories, and unfortunately you have to be humble. We don't have the answer. It may be increasing the risk, or maybe it's doing nothing. We just don't know. Probably there is not something dramatic, otherwise we would have seen it, but we haven't been studying it hard enough to know.
Any relationship? So an astute patient with narcolepsy recently diagnosed, concerned about long-term risks. Any relationship between narcolepsy and future risk of developing dementia?
I'm not aware of any association really in the development of dementia. So.
And the only study I know of that comes to mind is, I think, Plotzy that did skin biopsies on patients with, RBD acting out their dreams. So patients with RBD can go on to develop dementia. That's been well described when you follow them for 10 plus years. But fortunately, the RBD and narcolepsy, we don't think it's like that RBD. So that's good. And they did a study in patients with narcolepsy and RBD kind of symptoms that met the criteria. They did skin biopsies, and they didn't find the same risk factors in none of the narcolepsy patients with RBD. So that based on that study, that does not look like there's an increased risk of going on to develop Parkinson's. REM behavior disorder. So dream and act. So you're dreaming of fighting off some ominous figure, shadow, and you're doing this. And your bed partner sees you punching in the sky. You wake that bed partner up, and they said, I was fighting and trying to save my family's life. That's kind of RBD clinically. So that's good. So RBD, that kind of those kind of features do not look like it's the same as a idiopathic RBD that has an increased risk of going on to develop dementias, Parkinson's and stuff like that.
Yeah, and some people have suggested that actually having narcolepsy could protect against dementia, but it has never been proven for complex reason because there is some suggestions that hypocretin is actually being stimulates the release of amyloid beta, but that has not been proven one way or another.
And anything with narcolepsy and aging, am I going to live a normal life, duration-wise?
Yes.
That was the question. Narcolepsy and aging.
There's nothing that's ever been shown to suggest that longevity is curtailed.
And, although there's not a lot of
that's a
detailed
good
information about how to treat patients who are in their 80s and 90s, most of us have had patients who are very senior. My oldest patient was in his mid-90s. And because he was diagnosed so long ago, he never had an MSLT, but it was exceedingly clear that this person had narcolepsy with cataplexy and needed to be on medications, and it wasn't that much different than treating someone who was decades younger.
Here's an interesting question. Does an MWT provide value in determining if treatment is working? So when should we be using an MWT, right? So an MSLT is you tell the patient, fall asleep, try to fall asleep. An MWT, you say, stay awake, right? And so in pharmaceutical trials, that can be used to measure effectiveness of drugs. The other time that a sleep doc might get that is that a primary care, some doctor takes a patient with sleep apnea or narcolepsy, turns them into the DMV, and then takes their license away. Those are the two situations where that's the one situation as a clinician that it might come up for me in doing an MWT. I do not do an MWT to measure effectiveness of a medication clinically. Because if the patient's sitting in front of you and tells you that they're really, really sleepy still, and you have a positive, you have a diagnosis, who cares what that MWT is? Who cares? You probably be able to come up with little situations or whatnot, but does any of the panel use MWT clinically?
The only time it really comes up is if somebody needs it for work purposes. They need to show that some objective evidence to say that they're capable of doing their job, then we would do an MWT, but we don't use it for assessing efficacy of the drug, as you say.
And as everyone, especially Dr. Thorpy, knows well, MWTs are very common for clinical trials because it is a test that the FDA, the Food and Drug Administration, feels helps demonstrate that a drug is working compared to placebo. So that's one place where if you're in a clinical trial, you may well have MWTs. But that's not, day-to-day clinical practice. That's serving another purpose. I don't know if you want to say anything more about that. It's sort of a measure used in that one setting.
Aside from other emotions, is it possible for other environmental factors to trigger cataplexy episodes? Walking out of a sauna into a heavily air-conditioned locker, for example, walking out of a heavily air-conditioned building into a hot environment, Arizona heat. Arizona heat will cause a lot of things.
I think all the evidence that we have is that the most likely precipitant of narcolepsy is an infective etiology or with the vaccine from Europe, as we mentioned earlier. So I find that too few physicians actually ask about prior infections, and I certainly make it a habit of asking every patient to think about around the onset of their symptoms as to whether there was any particular infective infection that went on around that time. So I think as we collect more information, the information at the moment is, as Dr. Mignot mentioned, about the H1N1 virus, the Chinese data showing an association there. And there are sporadic cases with most other infections where people have reported before Lyme's disease, upper respiratory tract infection, mononucleosis, etc., that they develop symptoms of narcolepsy following that, although there's no good study that I know of looking at those other things, other than the streptococcal antigens, which Dr. Mignot has done, showing an association with onset of narcolepsy. So Looking for an effective etiology, I think, makes sense. But for many patients, it may be something extremely subtle. I mean, they may not even know. I mean, it's a bit like you can sort of have COVID and not even know that you've had COVID. And only the test will show that you've had COVID. Maybe the same thing happens in narcolepsy. Maybe people have some subtle infection that's never ever picked up or recognized, but it could be the precipitant for the disorder.
To point out one thing in relation, even these vaccines that triggered narcolepsy was again, it's not like it's one particular vaccine that was only available in Europe. The other vaccine didn't seem to cause an increase in narcolepsy. I want to make sure you understand the other flu, it was only this particular flu vaccine from Europe that seems to have caused that problem. And we still don't really understand why this vaccine was so bad. But even with this, it's only one person for 16,000 that developed narcolepsy. And one person over 4 or over 10, has the right genetic background. So it's not just an infection. We kind of know that this is one thing that may push you to the edge, but there's probably other things we have no idea of. So because between 1 for 16,000 and 1, there's still a lot of room for other things to be added to the infection to finally develop narcolepsy. So often I say that developing narcolepsy is probably a lot of bad luck. Unfortunately, you have the genetic background, then you had the infection at the wrong time, and you probably had even some other infection before at the right time or the wrong time at different times, and then it modified your immune system in ways that make you more susceptible at one specific time. But it's just like shooting in the bullseye, like across many circles and just going in the right target. It's really a lot of bad luck that has accumulated, and boom, you develop it. And I think that's the best way I think you can probably develop narcolepsy. But I think your question was more about cataplexy itself and how cataplexy can be recognized with
Other
laughing
triggers,
or
is
not
there
laughing.
other triggers for it?
And I think that's an important thing because a lot of people have expressed that. So indeed, cataplexy is sometimes triggered by other things. I mean, even stress, anger, etc.
So, and then getting back to the traumatic brain injury, what about head trauma? Disrupting the blood-brain barrier?
Yes, that could be a trigger, but it has never been shown. So we definitely need to understand better what other factors beside infection maybe could trigger narcolepsy. We're still missing things. Yeah.
And before we move on to, go ahead.
Cataplexy, I mean, some of the stories you hear that probably have an element of emotion would be, now I'm going to sound like I used to live in Minnesota, which I come by honestly. So someone is holding a fishing rod and then feels a fish bite, and they are excited, they are happy, and they no longer can hold the fishing rod, so they drop it in the lake. Or, I've heard people say they just can't play golf because they're about to hit the ball, they're excited, they sort of feel like they're in the groove, and they loosen their grip on the golf club. That's sort of a mixture of probably a happy feeling, not so much surprise, unless I'm the golfer. So I think there's some, if you listen to people who have cataplexy, you hear some interesting stories. Very often there's a bit of emotion there. I'm not myself familiar with going from a different temperature, unless, of course, maybe the person was surprised by something in that process.
Walking out of the airport in July, in Arizona.
Yes, so there are typical emotions, and when we have done a lot of clinical practice, we smell them, and we see the stories are often good, like meeting a good friend in the street, that you haven't seen for a long time, with an element of surprise and happiness. And in contrast, it is true that generally, stress is rather inhibitory, like fear or surprise, like doors that would slam, wouldn't produce cataplexy in most people. But like everything that I told you before, there is always exceptions. I had a patient that I know is totally no hypocretic, etc., and her emotions that she says was walking on a snail because it was disgusting. I mean, that's totally different, but that was one of her strong trigger in narcolepsy. And some other people told me it's a lot of fear sometimes. And so there's no real complete rule, but it is true that generally, if laughing or joking is not a trigger, it's much less frequent that it's truly narcolepsy type 1. But that doesn't mean never. There's never in medicine. That's really the thing that I want to tell you. It is true. You really see everything, and then at the end you make a decision, and sometimes that's when maybe a lumbar puncture will be more helpful, or an HLA. But also sometimes it may not matter how you're going to treat the patient. So, understanding is useful, but not always absolutely necessary.
And so our next section is going to be talking about medications. I know we dabbled on that subject matter already a little bit, but before we go there, what about lifestyle modifications? I've heard about this low-carb diet, any herbal remedies, supplements I can take. I really don't want to take a medication. Anything I can just do, some over-the-counter med, or can I just take naps? Do I really need a medication?
Yeah, I have patients that don't take any medication. I have everything. And I think we all have a small number of patients, maybe 2%, that have no medication at all and are doing okay. They just have a different lifestyle. They nap more. Yeah. They just, I think, again, narcolepsy doesn't occur in a vacuum. If you do the test, it's generally going to be positive. They're going to fall asleep very quickly and go into REM sleep, so they're clearly sleepy. But some people adapt better to having a disease, and you don't want to medicate people against their will, for sure. And I think in terms of lifestyle, I think everyone knows that napping is helpful. One of the difficulty is staying awake for a long period of time. So taking a nap is usually restorative, not always. Again, there's no perfect rule, especially in children. Children, sometimes they are so tired and so sleepy close to the onset that after a nap they can be super grumpy and even worse than before a nap. So it's not always. But in general, the naps are good. Respecting your nighttime sleep, trying to have a healthy habit and exercise, because again, people gain weight. Most people are heavy but not everyone. Some people in the audience, they have no hypocretin, but they're skinny, and that's the way it is. There is everything is possible.
I always say whatever's good for a patient without narcolepsy is even better for a patient with narcolepsy.
I think that's a very good thing. So, that's absolutely true.
This question is, do you think a patient with narcolepsy type 1 should avoid flu mist immunization, flu shot immunization? Dr. Maski, get your immunizations.
Yeah, get your immunizations. I think, to Emmanuel's point, the association with that particular vaccine, the pandemrix vaccine, seems to be very isolated, one-time event. They actually have looked at whether there was a bump in the incidence in this country around the same time, and there was, but it's more or less probably in a reporting effect. We knew about the European experience. Narcolepsy is a little bit more in the consciousness, and people come forward. I don't know if you want to say anything about your work.
Yeah, and I think that's my opinion, but of course not. I like to say that looking at what happened around this H1N1 story is a bit like looking at a map of Europe after the Napoleon Wars without knowing that Napoleon ever existed. It's very complicated. An infection arrives, people have had past infection, we don't know what was the history before this infection came. Then in Europe, people were vaccinated with this particular vaccine that was not used in the US, and they were vaccinated exactly the week where the flu arrived. So many patients were vaccinated on top of getting the flu. So that's one possibility, that this particular vaccine was very bad because it was given at the same time as a lot of people did catch the flu, but this is also controversial. We know that it was a very strong vaccine, whereas the vaccine that we used in the US didn't have an adjuvant, so it's much milder. It didn't protect as much the patients against the flu, but at the same time probably it stimulated less the immune system, so probably does not produce a big increase in risk. And probably getting the flu itself, we know that in China and in some countries, clearly they were not vaccinated at all, only a few percent were vaccinated against the H1N1, and there were a rise in the number of cases of narcolepsy, so probably getting the flu can cause narcolepsy itself. So you see, it's kind of a predisposition. Maybe with your vaccine, some cases, it allows them not to have a stronger flu that could produce narcolepsy, so maybe it's a bit protective. And in other, maybe it pushes them through the edge because they get the flu at the same time. We don't, but it's not a strong effect. And probably this particular vaccine that was used in Europe, this pandemic, was like a perfect storm. It was a too strong vaccine that was given at the wrong time when the infection occurred.
Okay.
So it's very particular event.
Here we go.
If you have narcolepsy, you definitely don't want to have a severe bout of flu on top of it or a bad case of COVID. So definitely get the vaccine.
Yeah, get vaccines.
Because too many patients do contact me and they put off getting vaccines. And I think that's the worst possible thing. I mean, you just don't want both conditions to be occurring.
And I had
Here's-
patients
hold on
who
one
during
second.
coronavirus, they were telling me, I'm sorry, I've read this thing about vaccines and narcolepsy. Can you write a letter about me not getting the coronavirus? I said, certainly not. I'm sorry, but there's no evidence whatsoever. And
Spend 2 minutes on medications here. So, do you think there's any benefit in quantifying severity of excessive daytime sleepiness with MSLT, PSG, MWT with regard to treatment recommendations?
Oh, that's a good question.
Yeah.
We don't know. Actually, it's really surprising that this actually hasn't been studied, to look at your MSLT and see if there's any predictive value to it in determining how well you do on treatment. It's a fantastic. We should do it.
Yes, I agree.
But that being said, the patients who have like a MSLT value of 7.9 versus someone who has a MSLT value of less than a minute, meaning that they fall asleep almost immediately, you would think that the 7.9 would do better with treatment, but actually, and it might be to Dr. Thorpy's effect, it's usually the people with the most severe disease report to us the most benefit in the medication management. At least that's my clinical experience.
Although the clinical studies actually have shown something different. They've shown that when you break down some of the newer medications and their effect on the NT1 and NT2, the patients with NT2 move more than the ones with NT1. And that may be just sort of a baseline effect, the fact that if you have NT1 and you have more severe sleepiness, it's harder to move it with medication, whereas if you have a milder degree of sleepiness, you can move it a little bit more. So there is some data from particularly the solriamfetol studies that showed there was a difference in those two populations.
And I'll say, I think this is an important question, but a very difficult one, because when a person hears their results and realizes that the testing showed how sleepy they were, I think that influences the patient, their family, and the physician to say, well, we really need to be aggressive here. And in keeping with Dr. Thorpy's comment, we need to perhaps more quickly or immediately move to medicines that are thought to be effective, but that may be more of a hassle and an inconvenience, but everyone's on board. So I think our behavior is influenced by those numbers. So it would be a hard study to do because it wouldn't be possible to really be blinded. It would take a very clever study design to address those issues.
Changing subjects entirely, but related to medications. Your patient with narcolepsy wants to talk about family planning. A young woman, fertile, interested in having kids in the next few years. What do you tell them before, during, after? And then what do you do when the infant's there? They have a baby in the house.
That's an easy question to answer.
Yeah, a couple sentences,
Yeah, that's a problem. It's not a couple sentence. Times is up. No, I mean, it's some discussion you have to have with the patient.
I guess
that's complicated.
And the most important thing I just want to emphasize is, I think you emphasized the modafinil data.
Right.
That's the newest thing that we should emphasize.
Modafinil is the drug that you certainly want to avoid in pregnancy. The other thing is that most drug-induced fetal malformations that occur within the first 60 days around the time of conception. So the advice I would give to somebody who is thinking, should I avoid medications, they may want to avoid them sort of around the time of conception and earlier on. Although, from all the information that we have so many patients that have been on medications throughout pregnancy and had normal healthy babies and normal pregnancies. So for most cases, the general recommendation is that somebody, if they need to have medication, then they should try to sort of have the lowest effective dose during pregnancy, and they don't necessarily need to eliminate it totally. I mean, ideally, in the ideal world, patients should be on no drugs through pregnancy, but if a patient has cataplexy and is pregnant and falls when they're 8 months pregnant, that's not good because they're not on medication. So you've got to balance the risk versus the benefits.
Another tricky scenario is someone who wants to be pregnant but is having a hard time. So that can be quite a prolonged process. And in that case, I find it helpful for the person to work closely with the reproductive endocrinologist who may be assisting them in the effort to get pregnant. But the problem there is to be off medicine for a really long time while you're trying to get pregnant. That's just a challenge.
I don't stop the medication, you know. I tell them to monitor their pregnancy very carefully because there is some tests that are very sensitive. You can almost get positive after 2 weeks after conception. So even, you know, faster than your the delayed menstruation. So in the first 2 weeks, there's not yet organogenesis. So it's almost like if something happened, you have a spontaneous abortion and it's like nothing had happened. So I think there's some controversies whether or not you should stop immediately, watch carefully, etc. But I think there's a paper by, I think the Wake Up Narcolepsy, Project Sleep, has a nice, you know, review where they have tried to look at different things. I think it's a very individual decision that you have to talk with each patient. You can't really get a general rule.
So we're going to skip evaluating effectiveness entirely. How to monitor your medications. I think it's just a patient-physician communication discussion. How are you doing with this and that? That would have been that topic. And then clinical trials. You know, I would just encourage you to visit clinicaltrials.gov to find out what research is in the pipeline. That is the truth. Every pharmaceutical company research study pretty much is required to post there. Actually, it's almost a requirement before they publish their results that they post that. So that's where you go. That's it. Let's give a big round of applause for the panel and all of you.